please.
Yeah, because accept that we are being recorded. Press got it.
Just give us a moment. We're trying to share the slide so that the audience can see it.
It's better than my television at home. This is.
Maybe while we wait for the slides, you just give a running commentary on the history, and we backtrack when we have the slides.
Yeah. So essentially, in summary, it's a 57-year-old gentleman.
Right.
Yeah, here we are. Yeah, okay, good. Excuse me. So in summary, we have a 57-year-old gentleman, multiple risk factors, hyperlipidemia, hypertension. He's an ex-smoker. He has a significant history of his intracranial aneurysm that's conservatively managed. The MRI brain done recently, a few months ago in August 2022, showed that there was a lobulated anterior communicating artery aneurysm measuring about 6 by 4 millimeters in size, and it was stable. Also has a history of asthma. Next slide, please. So he presented with an inferior STEMI just last month, in which pre-PCI was done to the RCA. He was noted to have actually double vessel disease, in which the culprit lesion was in the RCA, and there was a diffuse disease in the LAD. So during the primary PCI, a 3534 stent was deployed in the proximal to meet RCA, and the FOBA was actually done to the small RPDA. His baseline echo done shows that the EF is mildly impaired at 42% with warm motion abnormalities present. Next slide, please. This is the baseline ECG, which shows this ST elevation in the inferior leads. The next slide. These are his baseline investigations when he first came in. Hemoglobin was 12.8. He has chronic renal impairment with a creatinine of 132 and a calculated eGFR of 48.5. His LDL is elevated. He has no diabetes. Next slide, please. And these are the list of the medications that he was discharged on aspirin, ticagrelor, nebivolol, valsartan, statins, and dapagliflozin. Next slide. I'm going to show you the angiogram done on baseline. This is the REO cranial views and LEO caudal views. So of note that there is actually diffuse disease affecting the proximal to the mid LAD, and also some disease towards the very distal part of the LAD as well. On the caudal views, suggests that the circumflex is relatively normal with some minor disease. The left main looks normal as well. Yeah. There is some minor disease in the diagonal as well. That's better seen in this next clip. Can we show the next clip, please? All right. The next clip shows the AP cranial view. All right. You can see here again, diffuse disease from the proximal to the mid LAD with minor disease in the diagonal vessel, one of the first diagonal vessel. And there's another AP caudal view showing the disease, in the minor disease in the circumflex. So culprit vessel in the RCA, which has since been treated. And can we show the next slide? All right, this is the angiogram of the RCA after PCI. So in summary, we have, okay, all right, maybe just show the RCA after PCI, please. Yeah, okay, next slide. So in summary, we have a patient with diffuse disease in the LAD, 57-year-old, this 57-year-old gentleman with risk factors of hyperlipidemia and hypertension, presenting with a recent inferior STEMI in which primary PCI has been performed to the RCA. EF is 42% with chronic renal impairment with a calculated GFR of 48.5 mils. Yeah.
Okay, so if you can switch back over to the angio today, we'll show you what we have performed so far, and maybe later we can have the panel discuss what to do for the LAD. If you can switch over to the angiogram, please. Angiogram. Yeah, so we first check the RCA. The proximal RCA stent is still patent, very nicely so, no signs of early restenosis. This is the target today, a very diffuse LAD lesion, proximal to mid segment, some calcification, tortuosity, 2 diagonals, of note a wraparound LAD, and a distal apical tight stenosis as well. This is an Ikari guider, 6-friend system. We're going via the right radial. So these were the baseline shots that we have done, and maybe we could get some comments. What were your thoughts on the target lesion of LAD and the strategy of treatment?
So maybe we could ask the panel, James, on the, how would you treat this LAD? What would your strategy be here?
Yeah, so as mentioned, it's a very diffusely looking diseased LAD from the mid all the way up to almost the ostium. And I guess you could approach it with either functional or anatomical revascularization, and probably ideally both. You want to use all the tools available in the cath lab to help you achieve the best outcome for the patient. So, I mean, personally, I would probably, I think post PCI physiology would be very important here. I would use intracoronary imaging and identify optimal landing zones, pick a spot with lowest plaque burden, and then I would use physiology, potentially tools such as IFR to look for pullback gradients, and then see if I can perform a post-PCI IFR to see if I can functionally revasculate the patient.
And Bill, does that distal apical lesion concern you? Would you be focusing on that as well?
It's pretty distal, isn't it? I was looking at it, and you normally wouldn't go down there, but it's a wraparound LAD, and it's probably 2.5 down there. And, you know, it's going to be a shame to do a long length of stent in the proximal to mid LAD and have a significant part of the apex and infraapical wall not revascularized. I think I would do the proximal and mid LAD. I think I'd do the bulk of it first and then assess, and perhaps you could palpate that with a 2.0 balloon, and perhaps you could do a DV down there. You could size it, you could image it, but there's a lot of vessel beyond that stenosis, isn't there? But it is a long way down.
Would you ever put a stent right there in the apical LAD for this vessel? Oh, and why wouldn't you?
Well, I think it's going to be difficult to deliver. That would be number one. You might get a good angioplasty alone result, but you could put a 2.25 down there. It's only a short lesion, so I don't think it's going to be subject to a lot of shear stress or forces that are going to create problems. I guess that's the main reason to be worried about, where there's a lot of motion.
So Michael, I mean, in a non-diabetic, long LAD, the risk are to the branches, like diagonals, septals. Would you ever send this patient to bypass surgery despite lowish syntax score and non-diabetic?
Yeah, look, bypass would be a viable option here. The problem is that distal terminal branch of the LAD, and but it's a long lesion, and it's likely that you're going to use at least 3 stents here that will likely restenosis as well. The bypass is an option. I gather the surgeons would sometimes they skip, a graft beyond that, but it's so terminal that I wouldn't. I'd probably say I'd agree with Bill. I'd probably just over this with the view to having bypass in the future if needed, with a DEV, and then stent the rest. I wouldn't do FFR, IFR. I don't think there's any reason to do that. It's a very severely diffusely diseased vessel, and I would treat it. And the diagonals are small, and I wouldn't worry about those diagonals, and probably put in three long stents and balloon the distal vessel. Yeah.
I think that's a good point. How do we assess the importance of these diagonals? Sujitha, what's your opinion on these 2 diagonals?
I mean, I think if we went for the bypass option, especially with that distal LAD lesion, I mean, I think all they could do is probably put a Lima graft. And then for this situation, you're probably thinking about complete revascularization, so that I think they would have avoided, putting a graft on that diagonal. I mean, I don't think it's a too small of a vessel, it's probably at least a 2. So DCB to the diagonals is probably not unreasonable. And I think my approach to the LAD would be, yes, DCB distally, but even that prox to mid segment, it is a long segment of diffuse disease and probably over 50 millimeters. So I would consider like a hybrid approach, part DCB and part DES.
So it is Chinese New Year, and the Chinese particularly don't like to have their bodies open for the loss of qi, the life force. And of course, if you had to put stents in this, and this is a very common thing to do in Asia, Scott, you're imaging it. What's the probability you have to stent the left main when you do this?
Look, I don't think you have to stent the left main. I think these are really challenging cases, and you know, in an ideal world, I think James talked about, you know, you'd start distal, you'd do a pullback, and we've done this in some cases. The problem is that even if you find you get to sort of that proximal septal and the proximal disease is non-flow limiting, when you put an OCT down, you find the plaque burden there is very, very high. And we know that landing a stentage in there is not the same as, you know, leaving it untreated, because that's what, you know, you do with defer, right? You don't balloon it, you don't stent it. But as soon as we land a stentage or a balloon in a place with a significant plaque volume, we know we get edge dissections, and we know we get higher edge restenosis. So I must admit that in this sort of case of, for cost reasons, and, you know, I believe we should be using the right tools in the right patients, but if we start putting a pressure wire and an OCT in every patient, even my managers would be very unhappy. But I think so. You're going to have to use imaging to optimize this, because you're going to put long stents in, and you really want to deploy them. So I think this will turn out to be a really big vessel. I think you'll have at least a 3.0 stent distally, not necessarily at the apex. And I think you're going to have to stent right back the ostium, which I think you'll probably be close to 4.0. And, you know, then the debate is the apical LAD. And again, I think that's significantly bigger than you think it is. I mean, I think you probably can get a 2.25, not 2.5 at least in there. The diagonals, again, the good thing about using OCT, you'll be able to predict what happens to those diagonals. I'm not worried about the second diagonal. The first diagonal, you know, is a bigger vessel with some osteal disease, and the B angle is not particularly high. So that would be the one that I would probably wire and use a keep it open strategy. I mean, there's two diagonals, you know, the circumflex is big, and what CTA has told us, it means it's very unlikely that diagonal is going to sub 10% of the myocardium. So I would keep it open, wire the first diagonal, stent, OCT guided.
So I think in summary, yeah, PCI, probably end up with 2, maybe 3 long stents. Most likely don't need to do the left main, but we'll check the landing zones and all the areas. Most likely at least 1 wire to protect that big first diagonal. And we reserve the right to stent the apical LAD if we know how big it is. Could be a 3.0 stent. And choice of imaging, there's Dougal, you're a big OCT man. Mild renal, some real dysfunction here.
Yeah, I think both modalities are good, and I think it's what you're familiar with. And if you do lots of IVUS, I think IVUS would be fine here, but OCT will tell you a bit more, and Scott's talking about the soft plaque and where you're going to land your stents, and I think probably OCT would be very helpful.
So how far have we gone? What was your plan in Singapore for this patient?
Thanks, Sydney, and thanks for the panels for the excellent discussion. I think those were the consideration as well. He's a relatively young person with mildly impaired EM, diabetes, as well as diffuse LAD. The consideration of CABG is there, and appropriately so. His young age, as well as the diffuseness, both involving the diffuse mid part as well as the apical LAD, may make revascularization and lima less effective with areas of ischemia. And that's the reason why we would choose PCI and try to preserve as much of the landing zone for future bypass if needed, yet achieve revascularization as much as possible. So I just showed you what we have done today. We have wired the wraparound LED as well as the larger diagonal. We pre-dilated with a 2.0 balloon. This is a 2.0 balloon, including the apical LED and back across the LED. we were planning to do an IVUS guided PCI as well as drug-eluting balloon. This is the angiogram immediately post the 2.0 balloon. We were hoping to get away maybe with a drug-eluting balloon in the mid part, but looking at this dissection, the plan is not going to work. We probably need to stance the very dissected mid portion of the LAD right to the proximal LAD. And we went ahead to do IVUS to confirm that that means stenting is not required. There is calcium and tortuosity of the LAD. This was a difficulty in delivering the IVUS catheter. This was as far as we could bring the IVUS catheter down. We went up with a 2.5 NC Scorfax balloon. And subsequently, we were able to deliver the IVUS catheter. Maybe we switch over to IVUS and for Jiang to explain.
Why don't we show the IVUS first? So this is, I'll just display. Yeah, this is the automated pullback. Diffuse disease, you can see that there's already coming through some mild to moderate disease coming up. It looks like a 2.5 vessel. We just passed a disease zone as well. You can see that there's some superficial ring of calcium extending earlier on from the 11 o'clock to 2 o'clock, now hovering around just earlier on, 12 to 2 o'clock. And this is where a very tight area is. And there's another superficial ring of calcium again coming through. Yeah. The lumen size now goes out a little bit better. And then it shrinks again, all right, to another superficial ring of calcium. But other than this, predominantly fibrous consistency. Again, another ring of calcium coming through. And some concentrated ring of calcium here. And here you can see that the diagonal wire coming out as well. The ostium appears intact. The lumen actually opens up again. And of interest, we were actually looking out for any particular landing zone in the osteo-LAD. So there is some disease here. You can see that there's no entirely disease-free zone at this point. And then it's opening up to the ostium part and to the left vein, as you can see. And this is the left vein. It's a big size vessel. Yeah. So can we pause the IVUS pullback here and then go to my bookmarks, bookmark 6. Yeah. So that is where I thought the osteo-LAD could be. There's some mild disease, and possibly I think we could land the device here with sparing the left main. And looking at the dimensions wise,
much more modification, right? Looked like it's quite balloon dilatable, and he had reasonable modification. Actually, we have Michael Nguyen on the panel, and has a great vast experience with scaffolds. And in the old days, when you have this sort of diffuse disease, you might put some scaffolds in the distal part of it so it dissolves. Were you doing that? Are you still doing that?
No, we're not. We're not doing that anymore. Yeah, we're just putting in stents. Look, who knows? I mean, Maris is not too bad, the data, but we'll see for long-term data. Was there a bit of dissection in the distal apical LAD? There was, wasn't there?
So one of the things that we saw, there was a big nodule of calcium, and you certainly wouldn't want to put a BVS. I would suggest
not at that spot. Anyway.
It was a pretty impressive nodule, and that may actually cause some difficulties with stent expansion, etc.
I must admit, I'd be tempted to use some lithotripsy just before I put the stent in there. It looked like a 180-degree quadrant in a couple of places. What do the rest of the panel think? Would they just get on and stent? And I can understand the operators wanting to get on with it with dissection.
You could tell there was going to be calcium in that section of LAD between the two diagonals, couldn't you? I mean, it was tortuous. You couldn't quite see the calcium on the angio, but I was actually reassured by the IVUS. It's not as bad as I thought it would be.
It's a very focal area, right?
Yeah, I think you can just...
you can see the top of the stent there, how it's sort of under expanded.
I have to say that
calcium is.
So the X-rays are always under reading calcium on occasion. So essentially, from my point of view, I've always wanted to have the 2 balloon marker balloon and just do a clear stent or stent boost and have a look at it just to be just get a look at the calcium, because sometimes
so that's with the balloon down.
Yeah, balloon down at the lesions.
Yeah, I think that's good.
But also, I think that not all calcified nodules are created equal in a sense. I don't mind the idea of just, lithotripsying, shockwaving that spot. That sounds very reasonable. But would you atherectomize that nodule? Scott, would you orbital atherectomy that?
Look, I think it was, I mean, there was diffuse moderate calcium and there was one calcified nodule, which was in a relatively focal area. And I guess it's a little bit different here because it's got a lot of dissection, but what I would normally do is take an NC balloon in that sort of situation where there's more focal calcification and, you know, inflate it, check it in 2 views. And if it looked like you got a pretty good result with the NC balloon, but no, making sure it's not an undersized NC balloon, then I wouldn't. But if there was, you know, signs that we weren't going to get expansion, I would. So what I'm interested in is, you're taking on a stent right back the ostium, the LAD. Is that correct?
Yeah. So thanks very much for the discussion. So we decided that we treat the distal LAD with the drug-eluting balloon.
So maybe I'll show you the results. We went ahead in the interest of time while there was discussion. So this was after the pre-dilatation and IVUS. We repositioned the wire. This was a drug-eluting balloon, a sequence piece 20 by 20. Okay, so looks well expanded. And this was after the drug-eluting balloon. Okay, would anybody treat any further for the distal LAD or accept this result?
I guess I'm quite interested because I know in Asia, you know, there's a lot of use of drug-eluting balloons. They're very popular, particularly for small or distal vessels. So what is your criteria for saying that you've got a satisfactory result from your drug-eluting balloon? So when you do a DEB, what criteria do you use? You've got IVUS to decide that, you know, you've got a satisfactory result with the DEB and you don't need to do anything more.
Yeah, well, Andrew.
Yeah, thanks for the excellent question. So it can be either angiographical diagnosis, IVUS, or functional evaluation. Angiographically, 3 main diagnoses: how's the flow, TIMI flow, whether it's slow, fast, residual stenosis, whether it's less than 30%, whether there is any flow limiting dissection. If there's none and the results good, less than 30% restenosis, narrowing, residual narrowing with good flow, then we'll accept this result. Yeah, we can supplement with FFR if there's any doubt of the success of the DEB as well.
So it's a little hard to see here, but it looks like you've got a sort of 50% residual stenosis, and there's a suspicion that there may be a degree of dissection, albeit small. So would you IVUS this to decide, or were you just happy with that result?
Maybe
You're referring to the mid LAD or the distal LAD? The distal LAD.
Apical.
Apical.
Yeah.
Yeah, it may be a little bit difficult to have enough length to deliver the IVUS catheter around this wraparound LAD. The flow is good, and it's not likely that we want to stent this distal portion of the LAD as well. I would accept residual stenosis about 30%. In a small dissection, the flow is good, I will accept it as well. So I'm likely to accept a little bit more suboptimal result for this apical LAD.
Yeah, maybe I could ask Bill, are there disadvantages of actually putting the stent in apically?
I don't know, to be honest. I've never put a stent down that far, close, but that's a long way down. I'm happy that it's a satisfactory result. What I would do in this situation is probably get on with the rest of the case and reassess it at the end. And if it still looks satisfactory, then I'd be happy. But if it sort of deteriorates during the procedure and starts to close down again, then that might be a reason to sort of IVUS it. But you've still got a little bit of work to do proximally, and you can reassess the distal LAD at the end of the procedure.
That sounds very logical, because the reason to do a drug-eluting balloon is a stable, POBA, reasonably good result with a small residual, hopefully less than 30% and without much dissection. I guess that in my mind is that you just live with a closure rate or subacute closure rate for the next 24 hours. That may not be great. And so we've limited our drug-eluting balloon use, not to de novo proximal lesions. We tend to avoid them. put metallic DS in them, but distal branch vessels and things you don't think is going to do well to stent, the drug-eluting balloon may be good. Sarah?
Yeah, so we've taken the liberty to actually stent the mid portion. So as with the IVUS, we were anticipating because of the tortuosity as well as the calcification that there may be some resistance with delivering the stents. As rightly anticipated, because of the tortuosity, there was some resistance initially delivering the stent. I saved the fluoroscopic image. We're using Ikari left guider. The active support is with the opposite end of the aorta. So we really have to deep seat as well as get the support from the opposite end, wire down, and you can see that we made slow progress across the band, delivering this 38 stents across the LAD. And positioning.
So this is a 2538 Synergy XD. We chose this because it's deliverable and to hopefully overcome the tortuosity and the difficulties that we had previously.
Yeah. So we're aiming for the last septal to be distal from the last septal. This is inflating at nominal and subsequently inflated at 16 atmosphere. So this was the balloon expansion of the 2.5 balloon taken to 16 atmosphere. Looks well dilated with a balloon of 38 in place. We use that as a measurement of length as well. So any comments on the stent so far and the adequacy of stenting?
Yeah,
so we're going to place a proximal LED
stent. Looks good from what we can see here. Maybe I could ask the panel, are we concerned about where we position the stent with preserving that first diagonal? James?
Yeah, I think the mid LED stent position is satisfactory. I was I think Scott mentioned earlier, I was on the IVUS. I wondered if the proximal LED plaque extended into the distal left main and whether the second stent, whether there's any discussions as to the landing spot for the proximal LED stent, whether or not we should be considering crossover stenting or
do an
ostial LED.
Okay, maybe we interrupt the discussion. We're placed now a proximal LED stent. We have done IVUS. The left main is not severely diseased. We thought we could land the stent near the ostium of the LED. The two good views that we have found were a steep areocranial or areocaudal to help us position the position. We have taken the areocranial. Now is the areocaudal shots. So it's going to give you a picture of this. Maybe you could point back to steep areocranial. Anybody, what do everybody think about the position of the LED stents?
Yes, sometimes we mark those landing spots with sort of co-reg, poor man's co-reg with an angiogram with the IVUS catheter in the proximal part as well as the distal landing zone. But I think that we have a world expert on IVUS, real-time IVUS guided stenting of osteal lesions here. And so maybe Scott can tell us, would you routinely do, it's a 6 French guiding catheter, a bit more difficult.
Yeah, so you can't do it through a 6 French guiding catheter, that's the first thing. So you do need a 7 French, but I must admit, I would have started this case with a 7 French for a number of reasons, because just delivery in terms of if you end up having to use a guide extension, you've got to do kissing balloons into a branch or something, it just becomes complicated. And with the sheathless catheters, you can use 7 French for the radial. So we routinely would do a case like this with real-time IVUS placement for 2 reasons. Actually, what it does is and you can be very sure about where you land it and get a pretty reproducible, very reproducible result. And the problem is, sometimes what looks good on angiography isn't good on imaging, and it's about making it predictable. I think 50% of the time you land it where you want to, but an angiogram 50% of the time you're sort of surprised where it's landed. So maybe the trick is, if you do it angiographically, not to image afterwards.
and Scott, do you get a bit of wire bias with so much gear in the left main with an IVUS in the circuit and the stent in the LAD? Is it difficult to maneuver the LAD or the IVUS?
Well, because the idea is that you pass the IVUS down and then basically you're just pulling the IVUS back and forth in the sheath. You have to use the Boston one because of low profile. So you're not actually moving the IVUS catheter as such, you're moving the transducer within the sheath. And I think one of the things that it does do is, as you say, it actually stops movement because you've got a wire and an IVUS in the branch, and then you've got the stent, and you tend to get less motion of the stent.
So it's good for stabilizing. You don't have to do pacing or anything like that, like in TAVI.
16.
Sarah.
Can I just ask a quick question to the panel and people's thoughts about, we talked about a keep it open strategy here, and just people's comments about when you would choose a gel balloon technique. You know, put a small balloon into the diagonal to keep it open versus just the wire. Maybe Scott might want to comment on that.
Gel balloon technique.
The EBC have talked about this for a number of years, and in Asia, retained microcatheters has sort of been promoted as a way of keeping branches open. So rather than just keep a wire, you can either put a microcatheter and jail it, or put an inflated balloon across and jail that. I think the key about that is when you've got a side branch that's very high risk of loss, but you don't want a stent and you don't want a balloon. It's usually because it's diffusely diseased, but still covers a reasonable territory. The main thing is if you're going to jail a balloon, then you want the tip of the balloon extending outside the proximal part of the stent. So you want to gel part of the balloon, but not.
So the other thing is to leave your stent balloon in place in case if you have to inflate your gel balloon, you don't want to distort the stent so you can't recross it, so that you can reinflate your stent balloon. But the Saito variation of the gel balloon technique is a short balloon. There's actually at the carina. So I didn't quite understand why you want to do that, but he's done a whole series of cases.
And have we got much data on that? Because you must be worried about mangling the main vessel stent on removing this balloon.
So the answer is there is no data. And we've actually started doing a little bit of bench testing and done OCT on probably about 10 cases where we've used retained balloon or retained corsair. And actually it's surprising because you see very little deformation of the stent. Obviously you pot afterwards, that sort of thing. But even if you do it before you pot, you don't see a great deformation of the stent. I guess it's because, you know, actually the volume of a low profile microcatheter is not huge, or unexpanded 2.0 balloon is not huge. You know, I'm sure there is one or two struts that are unopposed around the ostium even after a pot, but it's certainly not. I was pretty worried that you'd do an OCT or on the bench, it just looked terrible, but it doesn't.
Okay, so what we have done is we have stented the proximal LED.
Undoubtedly.
So it looks as though you nailed the osteo LED with that second stent.
Just a few words before I lose my microphone. There are many different ways to do the case. Obviously, if it was my case, I would do IVUS guided ostial LED, 2 stents exactly the same. But I would do apical ballooning the very last thing in the case, because I want to do only one injection in the end. Because ongoing injections pressurize that dissection. I would just use 1.5 or 2.0 balloon for distal. Before deploying the second proximal ostial LED stent, I would pre-treat diagonal with 2.0 NC and maybe 20 or 30 millimeter by 2 DEB. That's what Darren Walters published about 8-9 years ago, and then deploy the stent. That's the only difference.
Yeah. Maybe we can switch over to the IVUS.
And what the panel think about that? My always worry is about pre-treating the side branch as you get dissection, and then you're almost forced to do something to the side branch. Mate, what's your opinion, Michael? Would you pre-treat this side branch before you put the second stent in?
I tend to pre-treat if it's very severely stenosed and I'm really worried about losing it. If I'm not that worried and it's a small vessel, I'd never pre-treat. But if it's something I don't want to lose, then I tend to pre-treat. Did you post dilate with the wire in at high pressure? Is that right?
Yeah, we actually post dilated with NC trio at a mid segment and up to 3.5 at a proximal LED. Can we show the all this is seeing the IVUS pictures now live?
Yeah, we can see the IVUS here.
Yeah.
Do you worry about post-dilating high pressure with the wire in at side branch?
So
and not
far, I
being
think,
able
Yeah,
to-
with the diagonal end, yes.
So this is the left main. Yeah. Yeah. Maybe I'll just do a auto manual pullback. So this is where the distal segment is. Some elliptical expansion, maybe constrained by some calcium, but we actually, the vessel size did reach 3.0 and it's reasonably expanded, quite symmetrical here. No obvious malabsorption that I can see. Here there is some area of focal constrainment by the calcium.
Yeah, that's where that
Yeah,
nodule
so we can
comes.
discuss whether we want to do some further optimization with perhaps NC30 at higher pressures at this level. This is where quite near to the area of overlap between the 30 synergy and the 2.5 synergy. Some area of constrainment here. Here the vessel opens out again quite nicely, symmetrical expansion. Here we actually went out with a 3.5 NC already. Just pulling through. I think that's where probably the diagonal is. Yep, that's where the diagonal wire coming out through at 2 o'clock.
So we might poll the audience. 3.0 NC balloon at what high pressures, like 20 atmospheres, or shockwave balloon 3.0.
Proximal LED.
Or OPN balloon. So how about the NC balloon 3.0 high pressure?
This is the left
Who would do
main,
that?
this is the osteo LED. I think this
How about
is-
OPN balloon?
Yeah. Bookmark
Okay,
here.
3.0 OPN and shockwave for the nodule.
So perfect
Just a little bit.
placement.
NC's
So,
most likely, I think. OPN
So I'm
also.
looking at the osteo LED now. I think this is quite near to the ostium, quite near to the exact ostium. And that's the left main coming through. Yeah.
We did have a run of the very distal apical LED as well in the earlier recorded run. No, maybe Jiang, you can go through
Maybe
that.
show the
Very
earlier run. Yeah. So this is the IVUS of the distal LED. No obvious actually dissection that I can see from here, and I think quite reasonable lumen expansion, less than 30% residual stenosis. Maybe you can ask the panel whether there's anything else they want to do for the distal LED or not. But angiographically, I thought that the symmetry flow, no significant flow limiting dissection. Yeah.
Maybe I could ask Sujitha, what would you do with this apical LED? Would you do anything more?
I would probably just leave it and wait for it to heal and probably grow over time.
I must admit, I'd be worried about chronic metal fatigue if I put a stent in this apex. There's a lot of movement down there at the apex, and maybe balloon long term is better.
So you wouldn't want to cross the apex. What I mean, you just have the end before, straight apart.
Can we see, have you got pictures of that first diagonal? We're a bit worried about the bifurcation there.
First diagonal. It is disease to begin with. In this areocranial, we can do an aleocranial view as well to assess the diagonal more accurately. Why don't you do both cranial? Center, please.
Yeah, so 3 millimeters, you're getting 7 at least, so it's almost 8 there, millimeters square.
So we managed to bookmark the osteo LED. The stand area is about 7.5 mm square. And
anybody will do anything to that diagonal?
Yeah, perhaps the panel could help, James. Anyone do? Yeah, we'll go through the panel. Yes or no? Would you do anything to the diagonal?
I probably wouldn't at this stage. I think there's good symmetry flow in the diagonal, and I don't want to risk mangling the LED stand, so I probably would leave it.
So, Bill?
Yeah, I'd post-dilate that section in the mid-LED that needed a bit more, and then I'd pull the wire and have a look.
So, Michael, would you rewire Drug-eluting balloon? Or?
No, definitely not. It's small. I mean, what are you going to do? It's really small. I wouldn't do anything to that.
Sujitha?
I would leave it as well. If anything, I probably would have like DCB'd it like earlier on at the start, but not anything. There's TIMI3 flow now.
Certainly, there's a place here to do a pot for that in the main vessel where the first diagonal comes off. You may actually get better flow down the diagonal after proximal
What size
optimization.
balloon in this case would you do?
I think you've got to use the balloon size for the proximal vessel before the branch. So you're probably going to use a 3.5 NC balloon, possibly a 4.0 actually.
Yeah, so this is a 3.5 NC already. Would the panel actually suggest to leave it as it is, or would you want to do further post-dilatation for the proximal LED?
So that 3.5 was after the IVUS, was it?
So as a pot in the proximal part?
Was that before or after the IVUS, the balloon dilatation?
This was, the IVUS was done after the post-dilatation already. So we managed to get areas of about 7.7 and the osteo LED.
Yeah, I mean, that's very reasonable. I think the concern really is in the mid-LAD, you've got that area of, relative underexpansion where that nodular calcium was, distal to the diagonal. And I mean, I wouldn't do anything to the diagonal myself. I'd remove the wire, but I guess the question is if you were going to do more post-dilation at this point, that's when I would rewire the diagonal before I remove the wire so that I still had control of it. Because if you sort of go doing more post-dilation, you may find that that diagonal is then gone if that post-dilation is going to be over the diagonal. And then at least if you've got a wire down it, you've got control over it. But it's just one that you don't want to close, because if it does close, then you're going to get a periprocedural infarct.
Can I ask anyone in the panel whether you use lithotripsy post-stenting for this calcium nodule? I know it's been described.
Post-stenting, they've always, I think they've all had it. I mean, originally when it was released, people say, oh, bring back all those patients that had stents in with hourglasses. And so off you go. And they all seem to work pretty well, impressed. So the question is,
taken the liberty to remove the diagonal wire. This is the angiogram after the diagonal wire has been removed. Anything else we would need to do? Or should we end the case?
Number one is that you've achieved an MSA. Is that the MSA? You've achieved an MSA over 5.5. And we know the MSA is the major determinant of events so far. But from the reanalysis from ADEPT, from Fujimori's paper, is that actually at the site of MSA, if you are very underdeployed, like less than 39%, you're more likely to have TLR or 10% thrombosis at 2 years. That's despite in that cohort achieving 6 millimeters squared. So essentially, I guess we're over that already. And that looks better than 40% expanded in that site. So I don't think I would chase it.
No. I mean, it's a 4.0 vessel, so you could have done it with a 4.0, potted with a 4.0. But, that's an acceptable result. Once you get up towards 8 millimeters squared, your restenosis rates are very low.
Yeah.
I think the concern really is the mid. And then have we got the results of the poll? Because that'd be really interesting to see how people would approach that area in the mid.
Well, people put their hands up for, like, you put a stent in and you just put a stent in, you're unhappy with that spot, there's calcium around it, a nodule, whatever. Would you just shock it post-stent? Who would do that? I would. If you think that area is your MSA, it's very underdone.
Yeah, and I think you've got to be careful with calcified nodules because they can end up being a missile if you use an OPN balloon. They can just be a spear that perforates outside the vessel. So I think if we can modify it, that would be better.
That's probably keen on atherectomy the first time out. Orbital.
Yeah.
We've got 3 minutes left there, Singapore.
And actually, Sydney's talk, sometimes atherectomy, road ablation, particularly, you actually better to keep the side branch open with
So I think what you're trying to show
I think we're going to conclude soon. We actually measured the area over here.
It's over 5.
At where the focal enstrainment is. Yeah, okay.
Do a aerial corridor.
So it's about 5, almost 6 actually. So I think the guidelines suggest that we should achieve about 5 to 5.5 mm square. So based on IVUS, I thought we could just leave it as it is. So I think we're going to end the case.
Yeah,
This is
the
final
additional
pictures.
caudal shot to assess the distal apical LED. We don't see much dissection. There was a query on whether there was any dissection. Looks like a branch actually, but no obvious angiographical dissection. Flow is good. I'm leaving that distal LED as well. For the balloon, post-dilatation balloon, actually the balloon, we use a 3.5 post-dilatation balloon. The balloon is very well expanded. I don't think I can achieve anything different with any other balloon. So I'm gonna leave that segment as well.
I think that's very reasonable.
Okay, so I think thanks very much for your time and allowing us to share our case. So in summary, I think this is a patient that used an IVUS guided PCI to tackle a diffuse LED lesion. As shown in IVUS XPR as well, the use of IVUS can reduce the risk of TLR. And the results actually was shown clearly at 1 year and up to 5 years as well. This was presented in TCT a couple of years ago. And the challenges were that of a diffuse LED with tortuous LED. We managed to achieve adequate lesion preparation with a Scoreflex and managed to overcome it by delivering the Synergy XD, which is deliverable, down to the mid LED with some active support and a skill from Dr. Ho McCLean as well. And we will also mindful of the fact that to preserve the distal LED for perhaps potentially future surgical revascularization, and we decided to treat the distal LED with a DEB as well. Yeah.
Okay. Yeah.
Just want to find out.
Thank you very much. It's a fantastic case. Thank you.
Thank you very much for your time. Thank you so much. Thank you.
Thank you to the panel. Any additional comments before we go to afternoon tea? More caffeine.